In this lecture, we will cover Chapter 16, Transfusion Therapy in Selected Patients. So a big part of the role of the transfusion services or blood bank is to provide safe products to a variety of patients who may have a variety of situations going on that requires transfusion of a particular product. This can include patients like your sickle cell patients who just need that little bit of extra support that extends over the life of that patient, just to kind of give them cells, especially like when they're in crisis and things like that, to give them cells that are better able to provide that oxygen carrying capacity. You can have other unique situations that come about that will require some sort of transfusion therapy, like surgeries, traumas, things like that can happen. Now, each of these situations can be different based off of the scenario, the patient. There's a lot of factors that are involved, but the main role is just for the transfusion services to be able to provide those components that are required in a safe, to provide that product in a safe manner and provide a safe product where all your testing has been performed and various things like that. So we're just going to kind of discuss some of the various scenarios that come up in blood bank and various populations that will require transfusions and various things of the transfusion services department. So we'll just kind of briefly go over some of those and discuss those scenarios. Now, one of the things we've previously discussed in other lectures was the need for a massive transfusion. So anytime a patient has a rapid blood loss, that's considered a hemorrhage. And what this can do is actually initiate a series of complicated physiological response that involves the nervous system, hormonal changes, as well as it involves the circulatory system, including the heart. Now, if you have an acute blood loss of greater than 30% of the total blood volume, then what this can actually do is lead to a hemorrhagic shock. And so with that, you have symptoms of hypovolemia. And so when you have that rapid loss of blood volume, it can cause various responses within the body, and it will include things like reduced arterial pressure, hypertension, cooling of the extremities, a reduction in urine output, acidosis, so that acid-base balance starts getting out of whack. You will have increased respirations, and then you'll have decreased central venous pressure. So you're going to have a variety of the systems within the body that are starting to respond to this rapid blood loss. And so in order to prevent that, we want to try to infuse the patient with blood products in order to maintain that volume. And so once you reach the point that you have replaced one or more blood volumes within a 24-hour period, so you basically replace the whole volume of blood in that patient and within that 24-hour period. And usually with situations like that, it's going to happen pretty rapidly, within a few hours, because you're just giving products to the patient back to back to back. So it's usually you're going to replace it within a few hours. But there are some scenarios where that can happen over a 24-hour period where it's kind of extended out. But your textbook does say about 10 units of blood for a full replacement of the blood volume. Each facility will have a protocol, anywhere from 8 to 10. It will just depend on the patient. And of course, you know, each patient is different as far as their overall body weight anyway. So that blood volume could be more or less just depending on the patient. But once you've reached that point, your facility will have some sort of policy in place as far as how you will handle that. But the reason why you will want to transfuse a patient to replace that blood volume is to prevent that septic shock, hemorrhagic shock, and that hypovolemia that comes with that loss of that blood volume. And so the goal of transfusion is to correct the hypovolemia with crystalloids to be able to optimize that oxygen carry capacity, and then to maintain that hemostasis where you're replacing the platelets and the coagulation factors as well, to correct and avoid any sort of metabolic disturbances, so to kind of correct that acidosis that's taken place, and to maintain that intravascular volume for that patient. So you're basically, once you reach a certain point in that massive transfusion protocols, most places do a ratio of 1 to 1 to 1, where for every red cell unit you're giving a unit of fresh frozen plasma and a unit of the random donor platelets. Or it could be a protocol where you're doing a unit of blood, or X amount of blood, like 2 units of blood and an FFP, and then after so many, like 1 or 2 FFPs, and then you'll do a pooled platelet product. So whatever the protocol is set for your facility, that's what you will follow as far as that order of the blood products that you give to those patients. Now, there are some complications that can arise once you initiate that massive transfusion. So you've got to keep in mind that the patient is losing that blood volume. So you, on top of whatever is causing that blood volume to be lost in the first place, and then you're trying to replace it with volume back, then you've got all these complications that can happen on top of what's already going on. So the system itself is just pretty much in a state of shock. So once you start giving all of these products, then that can kind of initiate some other things that can happen. For example, you have the microvascular hemorrhage. So your patients can actually go into a state of DIC, and then you've got those coagulation factors and platelets that are being diluted out just because you're putting so much product in. So the treatment to that would be to replace it with your platelets, fresh frozen plasma, to try to offset those coagulation deficiencies. The patient can go have hypotension, so you've got to control that hypertension with trying to expand that volume that's within the patient. And so just when the patient is in that state, they're consuming those coagulation factors, they're consuming all of those platelets, and so what you're trying to do is just control the fact that the body is trying to stop the bleeding, as well as not really sure what to do with all of this new stuff that you're putting in. You can also have citrate toxicity. There's a decrease in ionized calcium from the anticoagulants that are in the blood products. So infusing at a slower rate, which may not be possible if the patient is rapidly bleeding out, or calcium replacement if it's really severe for that patient. The patient can also experience hypothermia, and so when you're infusing a lot of these products, you got to remember they're coming straight from the blood bank. They're stored on ice, or they're stored in your refrigerated coolers. So that blood product infusing in that patient is somewhere between 4 degrees Celsius, 10 degrees Celsius, somewhere in there. So when you're infusing a lot of products at once at those cooler temperatures, then you can actually cause a hypothermia within that patient. So one of the things that they can do is just when they're doing those rapid infusions is to use those blood warmers to help increase that temperature as it's going into the patient, so it's not as such as a shock, and you're not dealing with the hypovolemia on top of all of the other issues as well. So one of the things that are typically going to require the use of blood products is going to be cardiac surgeries. Now, when they do cardiac surgery or the coronary artery bypass graft, that's referred to as a CABG. So you'll hear that terminology right much in the lab, referring to a CABG or that cardiac artery bypass graft. And so what a CABG actually does is when you have any sort of blockage in the heart, when you've got those blockages that are preventing the blood flow to a particular area, then that tissue starts to die just because it's not getting that oxygenated blood flow. So when the arteries start to clog, once a patient gets that blockage, depending on how bad the blockage is, it could be determined that they need to have that bypass graft placed. So what they will actually do is take that vein, it could be artificial or from, I think there's been various trials where they've used various animals and things like that to do the bypass graft. But for the most part, what they will do is actually take it from the patient themselves, usually like a vein in the leg or arm or something. And then what they'll actually do is they'll just bypass that blocked part. So you can see here in these images where they've kind of designated what the blocked blockage is at. And then that graft will just come from that main area down to the area that is past the blockage to restore that blood flow to that area if that blockage is not able to be removed, like through some sort of catheterization or anything like that. So this is where the bypass graft comes in. Now, while patients are under and they're doing that bypass and things like that, patients can be put on a machine, one particularly is the ECMO machine, where it actually does oxygenation of those red cells outside of the heart. So it just kind of bypasses, usually they'll go in through the groin, and so that return can go in and out. And it will actually, the blood will get removed and it'll go through a pump and it goes through an oxygenator and then it's returned back to the patient. And so that allows the physician to do that cooling process and whatnot to work on the heart. Now, there are some things that can happen as a result of the patient being on this bypass machine, where there's a lot of factors that can be involved. And so it all has to do with the time on the pump, the patient's age, as well as the patient's overall health, whether or not there's previous cardiac surgeries, the particular procedure, if there's a valve replacement, just the CABG, both, any kind of medications the patient may have been on before the surgery, because again, we kind of know that aspirin and anticoagulants can have a factor in the patient's bleeding. The effects of the heparin, as well as decreased platelet function and from hypothermia. So depending on what's going on, the perfusionist that's actually monitoring the patient and this machine is looking at various things while the patient is on the machine. Cell savers could be used to maintain the patient's blood and stuff, the blood loss. But while the patient is on the machine, the perfusionist is looking at a variety of things that the patient is actually going through. So they're looking for signs of the hypothermia and things like that. So they may be doing some lab testing and stuff throughout the procedure, just kind of monitoring the patient to make sure that they don't need to give any additional support while they're on this bypass. So during surgery, the use of heparin can actually cause the PTT to be prolonged, and so that's one of the things that they're going to check, and then they're going to decide whether or not they need to treat that during surgery or while the patient is still on the ECMO, because sometimes, depending on the patient, they could leave them on even post-surgery just to kind of monitor them in case they might need to go back in and do additional surgery or anything like that. So, but they can replace with plasma and other various treatments that can be used to replace those coagulation factors and things. And so basically the perfusionist's job is to kind of monitor the patient, decide if they need to replace any of those products based off of how the patient is presenting. So with your neonatal and pediatric transfusions, there are issues that can arise with this population that's going to be different than the issues that will arise with adults, and it's due to the infant's smaller size, the hemoglobin changes, as well as the erythropoietin response that happens early in infancy. So if you have an ill neonate, they are more likely to receive a red blood cell transfusion than your other hospitalized patients. Now, transfusion issues that are unique to neonates include the changes from the hemoglobin F to the adult hemoglobin that can cause physiological anemia within the infancy stage. You can have that iatrogenic blood loss, and so this is when you actually have the blood loss that is due to actually collecting blood to do the testing on the infant. So if you're monitoring things like oxygen levels or hemoglobin levels or bilirubin or anything else, those repeat sticks of that infant to get that blood, the heel sticks, or it could possibly be venal puncture, then the infant is constantly losing blood due to having to check it. So when they already have that small blood volume, when you're constantly removing blood and they're not producing it as rapidly, then you may have to give a transfusion just based off of the fact that you're lowering that blood volume just from testing. They have a decreased response to erythropoietin. They have a low tolerance for hypothermia, so issuing anything that is going to cause that drop in temperature can affect that child. Greater risk of CMV infection because of the immune system is so immature at this point. There's a decreased ability for that infant to be able to metabolize the citrate or potassium, and there's also a decreased ability to restore the 2,3 DPG in any of the units that are older. So this is why we like to give fresh units. Now, we've already kind of mentioned a little bit about in previous lectures that you would need the mother sample to do that antibody screen and to do the cross match of those products if needed, especially if mom has any sort of antibodies. And then we'll also kind of cover this more in another lecture when we talk a little bit about mother-baby and the issues that can arise there. Now, products that are given to the infant are given in small aliquots, so we're doing small volumes. Obviously, the child has a smaller blood volume, so we're not going to infuse the same amount as we would an adult. So there are pediatric bags that are available. So the collection sets can collect multiple units in one, and so there's just a small aliquot in those bags. And you can see some examples here in these images of those smaller bags. Now the blood should be fresh CPDA blood, that way you minimize those 2,3 DPG levels since the infant can't deal with those. And you also are going to use leukoreduce, you're going to irradiate, and you're going to provide CMV negative units. Most often you're going to use your O negative blood for these infants. And so this is basically what you'll do for the transfusion of those infants. And your facility should have some sort of policy in place of how they will handle infant transfusions. Sometimes if you do not have access to the pediatric bags, then what you'll do is there'll be some sort of procedure in place where you'll just take a unit of your red blood cells that you have on your shelf and you will make aliquots out of that unit, but keeping in mind that once that unit is opened, then you have that 24-hour expiration when you store it in your cooler in the blood bank. And so you're either going to make those aliquots and use all of those within the 24-hour period, or you're going to end up having to dispose of that partial bag. Now, when you have patients with organ transplants that are getting an actual organ transplant, the transfusion support can differ a little bit just depending on the particular organ that is being transplanted. Now, with your liver transplants, this is actually associated with a massive hemorrhage, and that's due to that hypocoagulability. Remember, the liver is associated with those coagulation factors. The heart and lungs, so this is similar to your cardiac surgery, so you just want to provide leukoreduced components. With kidney transplants, the EPO is actually reduces the need for the transfusion, but leukoreduced products are good to help reduce the alloimmunization to the HLAs. The graft survival is enhanced when you actually do HLA matched donor recipient combinations. But of course, we're always going to give ABO compatible products. When there's actual organ that's not ABO compatible, that's going to be transplanted into the patient, then if that is a situation that happens, then they would have to actually treat it with therapeutic plasma exchanges and anti-rejection drugs. Hematopoietic progenitor cells to do a transplant. So your hematopoietic cells are actually your stem cells or your progenitor cells, and so this will be like what we would consider a stem cell transplant. Now, transplants can be allogenic, synogenic, or autologous. So allo is just going to be a random human donor, where there are actually animal donations, but we're not doing that with stem cell transplants. So it can be allogenic from a random donor, syngenic, which is through like an identical genotype, which would be like an identical twin, or autologous, where you do the donation of the stem cells yourself. Now, the sources could be bone marrow, umbilical cord, or peripheral blood source. And with your peripheral blood source, this will be following a colony stimulating factor that is given to the donor, and then a collection is done through an apheresis process. Now, transfusion of blood products, you would want to do leukoreduced red blood cells and platelets. You would want to irradiate those units to prevent graft versus host disease, and it should be ABO compatible for those products with the recipient, as well as the donor organ itself, or the donor stem cells themselves. Now, there are a variety of reasons why you would do a stem cell transplant that would include congenital immune deficiencies, malignancies, as well as some other things like multiple sclerosis, for example. Okay, so now let's just talk a little bit about the actual stem cell transplant itself and the ABO compatibility of that. So although your HLA compatibility is very crucial in making sure that you have a successful engraftment of a patient with those actual hematopoietic progenitor cells, ABO compatibility is actually not essential. So the early committed and uncommitted cells in these particular transplant do not possess those A, B, and H antigens. So therefore, approximately 40 to 50% of those stem cell transplants are going to be ABO incompatible. But you do have delayed engraftment that can happen when you do have any sort of major ABO incompatible transplant. So for example, if a group A donor is given to a group O recipient, and so you can actually see the presence of hemolysis that can happen even after your minor ABO incompatible transplant. So an example of that would be your group O donor going to your group A recipient. But again, when we're doing red blood cells and plasma products, we're going to make sure that they are compatible, like I stated, not only with the donor but also the recipient of that graft. There's also something that can be done that's called therapeutic apheresis. And so with therapeutic apheresis, it will actually remove abnormal cells, plasma, or plasma constituents. And this is in order to supply an essential substance that is absent within that patient, or to reduce the quantity of a particular antibody, modify some of the mediators that are causing any sort of inflammation, to clear any sort of immune complexes, or to replace some sort of cellular element. So with apheresis, you can just remove one particular product and then replace the original back into the patient. So for example, if you're removing just plasma, then it may go through a process of removing the plasma, returning the cellular elements back to the patient or that donor, and then whatever it's going to go through to clear out, if it's clearing out some of those immune processes and things like that, or those inflammatory mediators, then all of that's going to happen within that whole apheresis procedure within that machine that's doing that procedure. So here we have a chart that just kind of lists some of the different procedures that would be done and why you would do those procedures and what's actually happening during that process. So for example, if a patient has something like the Guillain-Barré syndrome, then plasmapheresis would be done to kind of help remove some of those inflammatory immune type of responses that have taken place that has caused that particular autoantibody to attack that individual. So you're essentially trying to remove some of those to lessen that attack on the body and hopefully get them back to a recovery state a lot quicker. And for your oncology patients, chemotherapy can actually result in a decrease of platelets, leukocytes, hemoglobin, hematocrit. Because remember, your chemotherapy is actually targeting those rapidly dividing cells. It's wanting to target those cancer cells, but it's targeting your normal cells as well. So side effects can include bleeding, anemia, and infection. So to try to help alleviate that, then transfusion may be required. Now, some of the things that may be required of that particular transfusion could include irradiated products, CMV negative, as well as HLA matched for your platelets. Now, there are some alternatives to transfusion, and these include your EPO, your colony stimulating factors, as well as DDAVP, which is going to help with that von Willebrand's factor that patients may need. Now, a lot of times patients that have chronic kidney disease and that are on dialysis will require transfusion. They'll usually do this while they're actually in the dialysis procedure. Now, some of the contributing factors that are associated with anemia in a chronic renal disease will be due to elevated uremia. And so what happens is you have an altering of the red blood cell shape that will actually cause the premature removal of those actual red blood cells. The dialysis procedure itself, because of what it has to go through as far as the blood coming out of the patient and going through this filtration process, can actually damage those red blood cells. So you can actually cause a little bit of hemolysis in those patients due to that damage to those red cells. And additionally, just the chronic renal disease in itself causes the kidneys itself to not be able to produce that hormone, that EPO hormone. So you have that's actually essential in the production of those red blood cells. So you have that low red blood cell production as a result of it. So with these patients, you're just going to kind of do the same thing you would do with most other patients as far as doing the ABO compatible products. Typically there's no need for leukoreduced, but most places have already gone to leukoreduced with their products. So just making sure you're given compatible products, as well as checking for those antibodies, because these patients are potentially getting transfused on a more regular basis, so they are more likely to develop those antibodies. With hemolytic uremic syndrome and thrombotic thrombocytopenia purpura, they do have similar symptoms. You have the thrombocytopenia, the microangiopathic hemolytic anemia, renal dysfunction, as well as central nervous system involvement. With both of these disorders, there's actually damage to the vessels endothelium that has activated and consumed the platelets themselves, and as well as the coagulation proteins. And so this is actually causing the microthrombi to become lodged within the kidney. So you start having a lot of these complications that result because of that. Now, treatment could include therapeutic plasma exchange daily for 1 to 2 weeks. You could transfuse plasma products as well as FFP. Depending on the situation, platelet transfusion can be contraindicated because of the fact that those platelets are kind of what's damaging or helping to activate that the damage that's taken place and causing those microthrombi. So until you can kind of get rid of the actual abnormal proteins in there, those platelets may not help us so much and could kind of actually cause problems. But depending on the situation, platelets may be necessary. So that's really going to kind of be where the attending physician will kind of monitor that. With your sickle cell patients, transfusion may be necessary to treat acute anemia, prevent stroke, or recurrent pain episodes. So about 25 to 30% of your patients that have sickle cell disease will actually develop an alloantibody. So with these patient populations, your facility may have a policy in place to make sure that you phenotype specific antigens in order to prevent an alloimmunization. So it would be like a D, your RH phenotype, as well as your KIL. With this patient population, you can have iron overload as a complication of the repeated transfusions, in those sickle cell patients, as well as any of your patients that have the thalassemias. And in order to kind of treat that, you would do the chelation therapy in order to kind of bind that iron and to prevent that iron overload from happening in those patients. With your immune hemolytic anemias, within this patient population, usually your red blood cells are removed from circulation a lot sooner than those 120 days. So they're constantly having low hemoglobins. Now, they can be divided into three groups. You have the autoimmune hemolytic anemia, as well as the cold and the warm are kind of grouped in this autoimmune category. You have the drug-induced hemolytic anemias, where the drug actually absorbs on the red blood cell membrane, or you have some sort of drug antibody complex that absorbs on that red blood cell membrane, or you have the drugs that actually cause some sort of autoantibody to be produced. The third group would be alloimmune hemolytic anemia, and so this is what is caused by when you have those hemolytic transfusion reactions or hemolytic disease of the fetus and newborn, and we'll discuss these particular complications in another lecture. With your hemostatic disorders, these are characterized by one or more coagulation proteins that are decreased or actually missing. The protein can also have normal production, but an actual abnormal structure. So symptoms can include prolonged bleeding, bleeding within the joints, and subcutaneous bleeding. So some of the common disorders that we associate with this would be von Willebrand's disease, hemophilia A, hemophilia B, and these are treated with factor concentrations or DDAVP, just depending on what the particular missing or abnormal production is actually taking place. Now, some alternatives to traditional transfusion of red blood cells, platelets, plasma will include things like growth factors. So with your growth factors, this is going to stimulate the bone marrow to actually start producing its own red blood cells, white blood cells, and platelets. You can have various blood derivatives like the various factors, antithrombin and protein C, as well as volume expanders to kind of assist in that volume expansion without using actual blood products. And this will include the crystalloids as well as the colloids.